You are welcome to my channel. Thanks for visiting. I will be going straight to prostate cancer diagnosis. Without further ado, let's now have a look at how we can make correct or accurate diagnosis of prostate cancer. Prostate cancer A to Z is right here. Through this link, you are going to find full info about 4 hours, even more than 4 hours, on everything you need to know about prostate cancer. So I titled it as Prostate Cancer A to Z. There are a lot of controversies when it comes to prostate cancer, but I've addressed all of them right here. Okay, let's get to the business. Prostate cancer. You know what this really stands for, right? Now, prostate gland is the main gland that we'll be addressing here. But is living in a community with some other neighbors, like renal system, gastrointestinal tract, and then when the cancer is moving around, it can go into the bones. Actually, it can spread anywhere, so all systems could be affected later on when it's pretty bad. Now, I've just said it. So when we're talking about prostate, the prostate will be somewhere here, but see the neighbors. This is adrenal gland. We will talk about this when it comes to hormonal therapy, okay, and the production of testosterone. This is the kidney. You can see the relationship between the kidney, the ureter here, that will pass the content from the kidney into the bladder, and this is the bladder neck, where the prostate, will be sitting, okay, will be located. So the urethra will pass through the prostate also. The urethra will be compressed by the enlarged prostate, just as it's going to compress the bladder neck and the nerve, boundaries around. So the urethra, TH, is different from ureter. Ureter is coming directly from the kidney into the bladder, while the urethra, TH, will take it out. Okay, so you can see the organs that are pretty close. We cannot see seminal vesicles here. No, I'll go into that in a bit. Now, there's no way we can talk about prostate cancer in details without referring to the gastrointestinal tract, particularly the large intestine, the anus, the rectum. Now, someone will ask, why bringing that skeleton here? Just to let you know, when we talk about metastasis, I will say metastasis to the bone, so it can spread everywhere. Now, the spinal cord is right inside the vertebrae, yeah? And even the brain can be affected in the central nervous system, right? And then, the entire skeletal system. Now, the prostate gland. This is one major buster along the journey of full information about prostatic cancer. Don't mind my sketch, I'm not a good artist. You can see the bladder here, okay, and just below the bladder, the bladder neck, you can see down here you will see the prostate gland itself, right? But you can see at this angle seminal vesicle. I'll talk about that later on. see the rectum and the anus. Now they are good neighbors, right? So from the anus, the probe of transrectal ultrasound could be passed, and the view of prostate is possible here. Okay. Then, if you look very carefully, you can see the testes, right? Now, some will call it testicle. Okay. And on top of it is the epididymis. And from there, you can see the vas deferens. Now, the vas deferens will go through and reach the seminal vesicle, then empty into this long one called urethra, urethra, okay? And the urethra, you could see, is passing through the prostate itself. And then the urethra will go through the penile and then empty outside. So you have seen how the prostate can affect the flow of urine. Then we have obstructive uropathy. I will go into full in a bit while talking about signs and symptoms. Then you can see that the testes that will be producing now testosterone is not far from where testosterone could have affect the prostate gland itself. And then this is the reason why we'll be talking about reproduction in male and the problem with prostate cancer and the probability of erectile dysfunction and, oligospermia, azoospermia, painful ejaculation, and even infertility. All because you have seen the relationship between the testes, epididymis, vas deferens, seminal vesicle, including prostate gland itself, that will produce one or two things to form the semen. So, yeah. Now, let me take you through some other things about the prostate gland. First of all, you need someone by your side from beginning till your full recovery when it comes to prostate cancer management. Now, the prostate gland itself is a sex gland in male, just like the testes or testicles, as you may call it, that are in Britain, UK or North America, just like seminal vesicles, testicles, and prostate gland. They are interrelated when it comes to male reproductive system. The prostate gland secretes fluid that will make up the semen, just like seminal vesicles will do. Now, about the size of the prostate gland is just like the size of a walnut or ping pong ball. It is situated below the bladder. You can see right here. This is the bladder here, and this is the prostate gland. Okay. It surrounds the upper part of the urethra. That is why when it is enlarged, either as a result of benign prostatic hyperplasia or as a result of the cancer, is going to compress the urethra, and then the flow of urine will be appreciably affected. The prostate gland is affected by sex hormones, and then the sex hormones here will do a few things. It can stimulate the prostate gland activities and also facilitate the replacement of the worn out cells of the prostate gland. So here testosterone is the chief commander that will do all these things. And the testosterone is produced right here from the testes. Some could be produced by the prostate gland, while some could be produced by adrenal gland, but majorly produced by the testicles. Okay. It's a small organ, the prostate gland, but when it is enlarged, then it gives us a big problem. When it is fed before any cancer, it is going to be robbery. Now, what are the functions of this prostate gland? It's responsible in part for the seminal fluid production and plays a role in hormone production as well. It helps to regulate urine flow. You can see that when it is enlarged, it's going to compress the flow of urine. There may be some problems associated with this prostate gland, like inflammation can occur here called prostatitis. When that happens, PSA level will be raised as well, just as it's going to be when there's benign. Benign means you don't need to run around. It's not likely going to kill you. Benign prostatic hyperplasia, right? And then another problem here is what we're addressing today. Prostatic carcinoma can all occur right here, in the prostate gland. Now, let me quickly touch on, I've been talking about lower urinary tract symptoms, So when this prostate gland is enlarged, then there'll be difficulty urinating and the individual may be straining because you are forcing the urine through this bladder to pass through the enlarged prostate that is compressing the urethra, the one with, TH, urethra, that will allow the urine to flow to the, outside of the man. I don't want to be repeating the name of that organ. You know what I'm talking about. So, the individual will have poor stream or weak urine flow, and the individual after peeing will feel as if the urine is still retained inside the bladder, incomplete empty. Not just feeling alone, that is the reality, because it's not going to flow fully. So weak flow or poor stream. Then bladder control will become poor somehow. So as a matter of fact, you have what is called urge incontinence. Then you can have hesitancy, you are about to pee, but you are afraid because it's difficult, it can be painful, so you hesitate to go to the toilet or washroom to pee. Then because of this incomplete emptying, then you'll be having what is known as intermittent stream. It comes, stop, comes again, and then after you have peed, part of it will be dribbling, post-micturition dribbling, and then you'll be there, in the toilet or washroom for a long time, so prolonged micturition. All these are what we collectively refer to as obstructive uropathy signs and symptoms. But at the same time, when you now have urinary retention in the bladder for a long time and you can't get it out, there may be backflow to the ureter, that is without H, ureter, and that one will also go back to the kidney, giving us hydronephrosis. So when this retention is taking place, that may be urinary tract infection right here, and then you then have irritative symptoms on top of the obstructive symptoms. And then you have frequency, urgency, you have nocturia and dysuria on top. So in females, there is no prostate gland per se, but we have a lookalike, which is known as homologous structure, called Skene's gland. That is SKENE, gland. That will secrete a whitish or viscous substance that will be released during female action. You understand what I'm talking about? I don't want to go into details of that. So there's no prostate gland per se in female, but we have homologous structure. They look alike. That is formed closely like the way prostate gland is being formed during embryogenesis. So the skin gland can also secrete PSA in females and PSA phosphatase. Though it is very rare, but the cancer of the skin gland may occur as well in females. It is related to something, and then I'm going to stop the details about prostate gland there. Like in men, it can serve as G-spot. Okay, so let's leave that as the detailed information about the prostate gland. Okay, I'm about to move away from the description of the prostate gland, but it will be incomplete without describing the histological zones. So the zones of the prostate gland. My poor sketch notwithstanding, pardon me, I'm not a good person when it comes to drawing. The important thing is passing the info across. So this is the prostate gland. This is the posterior part. The rectum is supposed to be somewhere here, and this is the anterior part. Okay. You can see the ureter coming from the kidney, dumping the urine in the bladder. The bladder is a sac, and here is the bladder neck. The urethra is going through. The TH1, right, is going through. Then anteriorly here is the fibromuscular stroma. That contains both smooth and striated muscles, and they form the internal and external urethral sphincter. That is fibromuscular, striated, and smooth muscle. Okay. Then we have the transitional zone. Remember the density the other time, right? And I said it's the part that surrounds the urethra. You see the urethra is passing through here, and the transitional zone of the prostate gland is surrounding it. This is the part that commonly becomes affected when we are dealing with BPH, benign prostatic hyperplasia. You can see why BPH could be very troublesome when it comes to obstructive uropathy, because when this is enlarged pretty close to the urethra, so easily it's going to compress it. That is transitional zone. Then we'll see the urethra. Okay, I'm getting to the peripheral zone. The peripheral zone is the largest of all the zones. If you just merely looking at it without even measuring anything, you can see that it is the largest. And it's right there at the back, posteriorly, okay, compared to the rest zones, right? So peripheral zone is the largest part, almost about 2/3 of the entire prostate gland histologically. Here, it is significant in the sense that it is located posteriorly. When I started, I said the rectum is supposed to be somewhere here. So when digital rectal examination is done, we are going to be feeling this. So the physician will feel almost the 2/3 of the prostate gland, but you'll be feeling the peripheral zone. So what about the other parts, of the prostate gland? And also another important fact about peripheral zone is this is where prostatitis occurs commonly, and from there it's going to spread to other parts of the body. And can anyone take a guess why it is that so? Well, and someone else might provide the reason, but my guess is since it is posterior and pretty close to the rectum. You understand now? Okay, so prostatitis from here, digital rectal examination ourselves will give us the picture of what is happening here. Hard, craggy, whatever you pick. Then you can see the ejaculatory duct, right? That's not part of these zones. So it's not passing through here and obliquely connected here, right? Then the last zone that I'm going to talk about is central zone. You can see the central zone here, and is surrounding what I've just mentioned now, ejaculatory duct. That is the central zone. So finally, prostate gland has 4 zones: fibromuscular stroma, transitional, peripheral, central. Ejaculatory duct is passing through the central zone. The transitional zone is the one caging the urethra, while the fibromuscular stroma is supplying smooth and striated muscles to guide internal and external urethral sphincter. Thanks for listening. Let's move on. Now, the diagnosis. At this juncture, I have an appeal to make, because prostatic cancer is all over the map. Therefore, we will look for it all over the place. Meaning, there is nothing so specific to tell us that once we get this, then it is the cancer of the prostate. So we have a long journey. The biopsy is not the first thing to do. So how do we get to make that the decision or determination that this man should have biopsy done? So we'll start with what is known as PSA, prostate specific antigen. I'll go into details in a bit. What is digital rectal examination all about? You also know. Transrectal ultrasound, is that necessary? Is it useful? Will that help us? We will know. CT, we understand now many people is familiar with CT, right? Do we need it here? Don't be in a hurry. Bone scan, why that? We are talking of prostate down there. What's the business of bone scan here? I will let you know why. Magnetic resonance imaging, and we are putting PMRI. Let me whet your appetite. Do you want to find out what PMRI is all about? Don't worry, we'll soon know. Now, PET, what is it all about? And PSA, PSMA, PET, what is it all about? Don't worry, in a bit we'll get there. Finally, the decision to have biopsy is now made after going round and round and round. How will it be reported? The biopsy, how will it be done? Are there complications? When it's reported as Gleason or TNM, to know the precise stage, whether the bad one or good one, we'll get into the details. Do we need other tests apart from all these ones? Remember, I have made reference to it that sometimes, based on associated comorbidities or the age, with life expectancy that is less than 10 years, we might just decide to watch and wait. Surveillance. But how are we going to make that determination without knowing other conditions in this man that will guide us to make such a final decision that we are not going to give any medication here? So you might have to do some other tests. all will be addressed here. So with that in mind, let's go and find out how your uncle, your brother, anyone, grandfather, grandpa, your dad, or yourself who have definitive diagnosis of prostate cancer. Now, PSA. This is prostate-specific antigen. It is an enzyme, but of course we know that there will be a protein, right? Secreted by the prostate gland. Some said that it is a tumor marker specific for prostate cancer. I disagree totally. I disagree. Why that? You will soon know that we can have high level of PSA and the man is not having prostate cancer. Also, we will soon know that we can have low level of PSA, yet the man is having prostate cancer. Then someone will ask, what is the point of having PSA there? Don't be in a hurry. We'll get the facts. Now, let's address the facts. Prostate-specific antigen is a protein made by a prostate gland epithelium, right? Normal prostate can make PSA, but in very, very small amount. Cancerous prostate gland can make PSA also, but sometimes we may not have high level of PSA yet the man is having prostate cancer. PSA is more in semen, but a good amount, appreciable amount is found in the circulatory system, in the blood. The PSA will help in liquefaction of the semen by breaking down the proteins formed from the seminal vesicles. There is no fixed level that is pathognomonic of cancer of the prostate. Medical students will enjoy this. There is no fixed level of PSA that is pathognomonic of cancer of the prostate. However, at a particular level, we may decide that other investigations should come, and that will guide us to having biopsy or not. But also remember clearly that low level of PSA may not rule out prostatic cancer. We only decide if other tests will be required to rule out prostate cancer when certain level of PSA is picked by us. For example, if we are getting 4 nanogram per mil or just greater than 3 nanogram per mil, we will call for more tests. Some establishments, some jurisdictions will even help the man by going lower, setting the bar pretty low to 2.5 nanogram per mil. That at the level of PSA of 2.5 nanogram per mil, more investigation should be done. Some authorities will put PSA between 4 to 10 nanogram per mil as the borderline range. Now, The mystery here is that higher PSA doesn't correlate per se with the presence of prostate cancer, while lower PSA is not enough to rule out prostatic cancer. It may be high, yet it is not prostate cancer. It may be low, yet it is prostate cancer. Then someone will ask, why this confusion? That is why the idiomatic expression had been stated earlier, that it is all over the map. But at the PSA of 10 nanogram per mil, it is more likely than not that we are dealing with prostate cancer, prostatic carcinoma. Now, some people will be interested, particularly medical students, in the PSA range per age. I'll give you the first year. A man between 40 and 49, if we are picking 0 to 2.5 nanogram per mil, we are fine. Compared to a man of 70 to 79, in a man of 70 to 79, 0 to 6 nanogram per mil is fine. In other words, the older you are, the higher the range of PSA in nanogram per mil that will be regarded as norm. This range could be lower in Asians. Black men at ages 40 to 49, well, black men generally are prone to having prostate cancer more than the rest. Caucasian will have a bit less than this value, for their own age group. And that will still be regarded as normal. While black men, they don't need to even worry about the PSA level. They should just go ahead with the full screening, particularly once there is positive family history of prostate cancer. So you are welcome on board. The journey has just started. PSA. If PSA is high and the individual is from the group, that's at high risk, like a black man with the uncle or father or nephew who had prostate cancer in the past, then we will not fold our arms. We will continue to our further test. But with that said, let's go and find out more about PSA and how we can make diagnosis of prostate cancer. Okay, long journey. PSA, like I've said repeatedly, there is no guarantee that the value of PSA is telling us there is cancer or there's no cancer. Whether low PSA can still occur in cancerous prostate gland. High value of PSA may not be as a result of prostate cancer. So if we pick high level of PSA, if I'm saying today that it might not be prostate cancer, then what can it be? Okay, now let's go through it. High level of PSA may be as a result of cancer of the prostate, might be as a result of benign prostatic hyperplasia, which will not kill the man. It will only cause discomfort and associated trouble like hydronephrosis, urinary tract infection, and that might be what will kill the man. Okay? It might be because you are getting older. We've gone through it. Don't let me go back. High PSA might be as a result of urinary tract infection. High PSA might be as a result of digital rectal examination. The doctor has just done DR.BEN'S, and you now ask PSA and you are telling me in his eye. And why will you? I wouldn't even ask you for the value of PSA once the history of digital rectal examination has just surfaced in this man that it has been done close to the time the sample was taken. Urological procedures. Someone has just visited urologist, and then they've passed their equipment, the probe and everything, and then not long from that time, you have PSA acid, and you are telling me it's high. I won't even look at it because of this. So it could be cancer, but it may not be. Let's see other conditions when PSA may be high, yet it is not prostatic cancer. Someone will say, this is annoying. Why will you keep repeating this? I will be repeating it so that it will sink into the brain. So there's no guarantee that low level of PSA is ruling out cancer, please. So if you go to a doctor, the PSA level is low, don't go and be pumping champagne that I don't have prostatic cancer. It may not be. It may be the opposite. You may have it. Okay. So the PSA could be high in trauma to the prostate gland. So it is high, yet it's not prostate cancer. So that's why I say I disagree with those who said PSA is pathognomonic or prostatic carcinoma. No. It might be secondary to exertion, like you are a biker, you've just done with your biking, and the sample is taken, it's likely going to be high. We could see what I wrote here, right? I don't have to say that loudly. And might be as a result of this ejaculation. PSA could be high when there is constipation that is so massive or severe. In inflammatory processes affecting the prostate gland, known as prostatitis, PSA level will be high. Simple procedure, like the other time I said urological procedures, I just remember that some nursing students might be listening to this, and then maybe we'll skip just simple bladder catheterization. Bladder catheterization through the urethra can also trigger the value of PSA up. Then parathyroid hormone high level can also correlate to high level of PSA. I put ETC because nobody knows it all. You might have some other points that I have not mentioned. So in other words, we have so many other conditions that can shoot up the PSA level, yet it is not prostatic cancer. But the low level level of PSA is not, the avenue or the good news to be celebrating that you don't have prostate cancer, because in 10 to 15% of prostate cancer, we may not have high level of PSA. Now, still on diagnosis, since there's no guarantee about low or high level of PSA, if the result is back and the question is it high? And the answer is yes, it is high. Then what follows? What is the next thing to do? Okay, the first thing we can quickly think of right now is, should we begin serial PSA or should we make a referral? Okay, we've taken the sample. PSA result is back. It's giving me concern, right? But not so much, not so scary. Then serial PSA will begin. So serial PSA begins. First thing first, we need to have baseline of the PSA value recorded today. Then, based on so many other factors, the age of the man, other associated comorbidities, we will start recording other values of PSA every 2 to 3 years. So every 2 years or every 3 years, you come back. Somebody will ask, why will you wait for a whole year or two? Prostatic cancer is not the type that grows very fast. But when you are back at the first 2 years and the difference between the baseline and the sample taken is so significant, then I will run. I will not wait for another 2, 3 years. Okay? So, baseline recorded today, next 2 years you are back, but depending on the value, I may not even wait for 2 or 3 years. I can say come back next year. Since higher PSA is just a sign, when the PSA is high, it's giving us the clue that in the next 5 to 10 years, this man will start having trouble with prostate cancer. So it's nothing that's going to start early, except when it is the aggressive type, fast-growing type. But majority will be slow growing. You understand what I'm saying now? We will stop serious testing if life expectancy in this man is less than 10 years. So why wasting our time? Even if we make definitive diagnosis, we're not going to do much. Because someone who, according to our books, will not live more than 10 years, that's what we do. Sometimes we understand how we make our prognosis and then determination of lifespan and everything, which many times it has proven us wrong. Some will live exact time predicted, some before, majority will even live longer. Let's put that aside. But according to our books, when the life expectancy is less than 10 years, we will stop serial testing. Okay? If there is no other comorbidities to reduce the life expectancy, I will continue with the serial PSA testing. Once it is not yet scary and there are no other signs and symptoms anywhere, I'll continue doing this till the age of 70. When you have your 70th birthday celebration, then I'll give you my gift by stopping your serial PSA. Referral will be made when the level of the PSA is 4 nanogram per mil or more, 4.0 nanogram per mil or more. But I'll talk about that later. We can also refer if we are getting 3 nanogram per mil in a young man. Like I said, we'll put so many things into consideration while doing the serial PSA or even the baseline. The baseline today is 4 nanogram per mil. I don't need to do serial PSA. I will refer. Or the baseline PSA today is 3 nanogram per mil, and this is a young man. I don't need to risk the life of this man. I will refer immediately. Okay? Because referral will become irrelevant when the value, the baseline value is high enough when you compare to the age, particularly the race again of the man before you. We need to ask some questions. Have you been taking alpha reductase inhibitors? Some people will say, why that? The reason is that if you're on finasteride or dutasteride, the medications, finasteride or dutasteride, can lower the value of PSA. You understand what I'm saying? Yet, we might be dealing with cancer somewhere, okay? Can lower the value of the PSA. But if you are on finasteride and dutasteride, and the PSA value is still rising while you're on this medication, the chances of you having prostatic cancer is pretty high. Let me explain further. You are an elderly man, or you have your father, or your brother, or your husband, or the grandpa, might even be your son, diagnosed with BPH, benign prostatic hyperplasia, and then the doctor has prescribed finasteride or dutasteride, and then you are visiting me, and I'm suspecting that we might be dealing with cancer, maybe because you're a black guy, and I will start the PSA, and the PSA is rising, despite the fact that you are on finasteride or dutasteride, and your PSA is still rising. I will refer you immediately to urologist for biopsy. You know why? That is a clue that you are likely battling with cancer already. There are some precautions to be taken while on serial PSA. We will make sure that you don't have digital rectal examination close to the time that we will take the sample for PSA. Also, we must have ruled out urinary tract infection, any urological procedures, advise you against biking, protect your perineum from trauma, even advise you to go on holiday away from your wife. You understand what I'm trying to say? I don't have to repeat it. And we will tell you to observe all this in about 2 months before you come for the PSA assay. This might be difficult for men. You understand what I'm saying? But it will be helpful so that we don't make wrong diagnosis, tell you that you have cancer, and you start all the expensive, traumatic procedures leading to definitive diagnosis or treatment when you don't need it. Then, when we've observed all the rules, and then the serial PSA is on, we will start observing some things. We will check the doubling time of the PSA. That is how long it takes for the PSA to double. For example, from 0.5 nanogram per mil to 1.0 nanogram per mil, or from 1.0 nanogram per mil to 2.0 nanogram per mil. We want to observe that. Okay? Then we check for velocity. That is the change in level over the time. So is it that the PSA is 2 to 3 PSA over 12 to 30 months? You understand what I'm saying? So not necessarily doubling, but from 1 to 2 nanogram per mil or 2 to 3 nanogram per mil. Sorry for the interruption. Now, free PSA to total PSA. In the course of serial PSA, we will check that, because it is going to be a good news when we pick more free PSA. More free PSA is likely as a result of non-cancerous cells of the prostate gland. So when we check the ratio of the free PSA to the total PSA, that could guide in determining biopsy or not. If free PSA of 50% or less is picked, some people can decide to have biopsy. Some can even go to as 10% of free PSA. If the value of free PSA is about 10%, some can call for biopsy right away. So now let me summarize here that when we get the ratio of free PSA to the total PSA, the more free PSA we pick, the better to say that we are not likely dealing with prostate cancer. The higher the level of the bond PSA, that is the unfree PSA, the worse it is, that is, the more the likelihood that we are dealing with prostate cancer. So we don't want the bond PSA, we want the free PSA. Okay? Now, let's consider another factor, that is the density. So before touching on density, let me quickly say something, that the whole essence of serial PSA is to give us clue whether the cancer cells are dividing rapidly or not. Because when they are dividing rapidly, we will know through PSA values. Then we'll be able to tell that this is an aggressive cancer or not. Now, back to the PSA density. We need to have ultrasound done at this time, and we will go through the rectum, transrectal ultrasound, while we will be taking PSA in the blood. So with the aid of that ultrasound, we can look at the size of the prostate gland itself. Then, when we tabulate the value of PSA acid through the blood, and we divide that by the volume of the prostate gland peak by the ultrasound, we will get the density. When the value is greater than 0.1, then we're in trouble. Some authorities will not even bother themselves about PSA density or not. Some will do something called the PSA and then the transition zone of the prostate gland will be taken. Okay, in that case, the part of the prostate that is making contact with the urethra, TH, that is the part that the ultrasound will assay as they want to pick the volume, okay, not the size of the entire prostate gland. So they use that as transition zone and then tabulate it as PSA then divided by the volume of the transition zone. So that is what some people will do. Majority will not even bother about all this, but for medical students and nursing students, it is okay for us to know that we can deal with all this. And then lastly, about serial PSA, because when you are doing serial PSA, what do you want to do with it? There's an entity known as statistical nomogram. In this case, we will use all the parameters available, like the free PSA level to the total PSA. We will consider, is this a black man, Asian man, white man? We will consider that. Then total history, any positive family history of prostatic cancer, how old are you? And then we will do so many other things like digital rectal examination, magnetic resonance imaging, CT, name it. We'll do everything that is expected to be done. And then we will now tabulate all this. The results, what we are able to pick, then we will all be put in a statistical nomogram. And from there, prediction could be made that this guy will likely have prostate cancer. And with that, we'll be landing up on this, because statistical nomogram is helpful, but not many physicians will have time to do all this. So from the statistical nomogram, it is also easy to predict whether this is an aggressive prostate cancer or benign one, based on the rate of growth. So it's helpful, but remember, PSA alone cannot be sufficient to make the prediction. So all other investigations will be put together and then make that prediction that we are dealing with this or not. Okay, my attention has been called into serial PSA, when to begin, and the disparity, as per referral. So that I should address when to refer again. Now, referral to the urologist will be necessary when PSA level of 4.0 nanogram per ml or greater is picked. But that is not fixed. Like I've said, and I'm going to repeat it here, everything about prostate cancer is not fixed. So we need those who really know about this seriously to handle it. Now, when I said 4.0 nanogram per mil, that is not fixed because you can refer as low as 3 nanogram per mil depending on the age of this man. Then, if this is a young man and you are picking 3 nanogram per mil, refer right now. This is a black man with positive family history. You are picking 2.5 to 3 nanogram per mil. Even if not in the other races where it is very common, because like I said, prostate cancer is found all over the world. Okay? This is a white man, Asian man. Even in the Asian man where we expect lower value. At a point, the value of PSA will give us the signal to refer. Okay? Then we may not bother to refer if life expectancy is not on the side of this man. This might be 60 years, 50, but with other comorbidities, like lung cancer is somewhere already, the bad one, and or some other problem somewhere. And according to our books, this man is not expected to live longer than 5-10 years. There's no need to bother a urologist about it now because there's nothing new he or she will do to ameliorate the condition. So, also, we will refer if this person has BPH on average reductase inhibitor like finasteride or dutasteride, where we don't expect the PSA to be rising, but unfortunately, it's rising pretty fast. Like this year, the baseline is 1.5 nanogram per mil on finasteride or dutasteride with the history of BPH, and then the same man 12 months after from 1.5 nanogram per mil is now 2.5 nanogram per mil or 3 nanogram per mil. Then I don't need any debate. I will pick the computer and make a referral. So, and finally on referral, we don't have to wait till we have serial PSA before we make referral. In some instances, if the baseline is high already, then referral is necessary today. You can see everything about prostate cancer is not fixed. Okay, let's check phosphatase. In this case, prostatic acid phosphatase. We don't need to bother ourselves about this. The reason why I've decided to put it here is I have tagged this presentation prostatic cancer A to Z, meaning everything you can think of about prostatic cancer will be found here. So this is not good, as a yardstick to say you have prostatic cancer or not. But if you have the money and the time, you can assay it. If you assay it and you assay PSA, then that may give you a better clue. However, PAP, that is prostatic acid phosphatase, is less specific to prostate cancer and it is less sensitive when determining whether or not you have prostate cancer. So we can summarize it or summarily say that it's not useful. And why that? Why the emphasis on not even thinking about it? It could be found in so many other cancerous conditions, even non-cancerous conditions, like any trouble or cancer, affecting the liver, the prostate gland itself, where we're going to find it mostly, but could be found in the testes, in lymph nodes, in red blood cells or leukemia, in bone marrow or the bone, and breast cancer, though not very commonly, and also in spleen and some other places that I have not mentioned. So, for the sake of medical students or nursing students, when you hear this, is a possibility, but it is not pathognomonic. Now, still on diagnosis, neither here nor there, right? We are still working. Let's see. Digital rectal examination. We go through the rectum, wear the glove, or put your gel or anesthesia or whatever. Then this cannot be used alone to determine whether we'll proceed to have biopsy or not. And we cannot say that, okay, I have done digital rectal examination, it is craggy and this and that, because of that, it is prostatic cancer. No, we cannot make a definitive diagnosis using DRE. You can not feel the entire prostate gland from here. You can only be dealing with the posterior part of the prostate. And at that point, we will not know what is happening at the anterior part of the prostate. So we can erroneously rule out prostate cancer because maybe the anterior part is the point where the cancer is, and we are feeling the posterior part of the prostate from the rectum. The ideal thing is we document that, okay, through DRE, I could feel that the posterior part of the prostate gland is so and so. Firm, rubbery, rough, craggy, hard, whatever. You are only feeling the posterior part of the prostate gland of that man. You don't know what is happening at the anterior part. If we say, okay, it is craggy, hard, oh, there is cancer of the prostate, without defining it to be posterior, and then we proceed to biopsy, well, whatever we find will determine what's next, but it is easier to rule out cancer of the prostate using digital rectal examination alone, and it might be erroneous. The findings can be added to other tests, okay? So we are not saying digital rectal examination is out of place completely. No, that's not what I'm saying here. But you can use it alone. So have your PSA level, have your transrectal ultrasound to look at the prostate, have your prostatic magnetic resonance image to determine whether you have the need for biopsy. Let the biopsy be done. Let's have the histology report. Then the grading is done by them, by the pathologist. Then we'll make a definitive diagnosis. So DRE is just a component, never alone. So if you've been to a doctor and the doctor says, okay, be in a recumbent position, DRE is done on you, and he removes his glove and he says, I'm sorry, you have prostate cancer. I don't know what to say. So I don't think anybody will do that. Okay, we are moving. Now, part of the investigations that could be done before arriving at definitive diagnosis will include magnetic resonance imaging. But in this case, you could see that I've added P. That is prostatic magnetic resonance imaging. Here we will use a contrast, and the name is gadolinium. With the help of that, we can see the soft tissues of the prostate gland itself. And that will help us with the help of multi-parametric magnetic resonance imaging to see the prostate gland and all other close organs around it, like testes, vas deferens, the bladder, the seminal vesicle, even the rectum. We'll be able to see that. Then we can also use this to guide the needle why biopsy is to be taken for the histology, okay? Histological studies, okay? Then, computed tomography, CT scan, that can reveal that there's metastasis to the pelvic structures or even distant metastasis. That can help. Then, positron emission tomography with the help of some tracers like sodium fluoride F18 and now then fluclovine or Pylarify or Posluma. All these could help to let us see, particularly with the help of prostate specific membrane antigen, to see clearly the prostate gland and the cancerous nature of it. Bone scan. Bone scan will give us the clue that we are dealing with metastasis, and precisely metastasis to the bone. In this case, we will need not only the scan, but the biopsy of the bone so that we can unequivocally, I repeat to be precise, that it is actually the secondary from the prostate cancer, because it could be from the breast or any other paired organ, right? Here we don't need much, just a small quantity of radioactive agent is needed for this. It becomes necessary to establish this because bone is a very good place for prostatic cancer to run to when they are spreading. Metastasis. The other friends that the prostate cancer will quickly run to once they are spreading will be the lymph nodes. Aside that, further away from the perineum will be the bone. Still on diagnosis, ultrasound. Don't say, what's the business of this man with ultrasound and prostate cancer? I have mentioned it times without number in the course of this presentation. Transrectal ultrasound will be helpful. Some call it endorectal ultrasound. Some will even be more precise and call it prostate sonogram. Whatever the nomenclature you give to it, this is a very good tool when it comes to diagnosis of prostate cancer, though it is not definitive. It is very good because very fast enough you get it done. No, so you just go through the rectum. We will come to this when PSA is high, and we need to determine PSA density. Remember, the other time when I was talking about serial PSA, part of what we will do during the time we are taking serial PSA is to determine the density. Okay? If we have high index of suspicion for prostatic carcinoma, then we'll call for transrectal ultrasound, otherwise known as prostate sonogram. This will be done before we have biopsy. Biopsy is always the last stage. And we can even use this ultrasound also to have biopsy done to guide, the needle. In this case, many will give prophylactic antibiotics, okay, and then with anesthesia. That is when you are using the ultrasound to have biopsy, okay. This transrectal ultrasonography is pretty helpful even in the treatment, like cryotherapy, you will know that maybe, brachytherapy, because something must guide us to know where the pellets of the radioactive agent will be implanted. It can determine the PSA density of transition zone, like I've said, going through the urethra, of the prostate gland. So, transrectal ultrasound is pretty helpful here. Okay. The biopsy. How do we get here? Now that we're talking about biopsy, why? How did we arrive at the decision to have biopsy? Well, the PSA is high. Other results are pointing to the high probability of prostate cancer. Remember statistical nomogram that I referred to the other time? Then, if that decision has been made that the next thing is biopsy, the biopsy will be taken by the specialist, urologist. It is called needle biopsy. Many samples will be taken, like 10 or even greater. Different samples from the same man, one prostate gland. But the samples will be taken from different parts of the prostate gland. That's it. And it could be taken through the perineal region. So we call that transperineal for transperineal biopsy. And that will be through the skin between the scrotum and anus. And it could also be taken through the rectal region. We call that transrectal for transrectal biopsy. That is through the rectum. Other equipment will be helpful here, like the ultrasound, transrectal ultrasound, magnetic resonance imaging, and sometimes we can combine both transrectal ultrasound with magnetic resonance imaging to guide the urologist appropriately to obtain the necessary samples. This is pretty good because we are now getting to making definitive diagnosis of prostate cancer. The biopsy is not without its own complications. There may be bloody ejaculation or blood-stained seep. There might be hematuria, and pelvic region discomfort is a probability. Some people will have nausea and vomiting, and some will develop infection later on and even urosepsis. Inflammatory process can set in, affecting the prostate gland, known as prostatitis. And you could see from the structure I showed you at the beginning of this presentation, the epididymis will be pretty close. So epididymitis can also occur. Of course, there might be perineal or urethral pain, including pain in the entire pelvic region. Since transrectal region is also a possibility of the route to the prostate gland, there might be rectal bleeding as well. So this is how a biopsy will be taken, and then the samples will be sent to the histopathologist, who will then tell us if we are right or wrong as per the presence of the prostate cancer. Okay, the biopsy has been taken. Samples sent to the histopathologist. Then we might hear the news. It is biopsy positive or suspicious or biopsy negative. When it is biopsy positive, it means that cancer cells have been seen in the samples. When it is biopsy suspicious, it means it's not quite definitive, meaning we cannot rule it out and we are not saying definitively that it is cancerous. However, it is abnormal. That is biopsy suspicious. In this case, we can have what is known as, biopsy suspicious, we can have what is known as low-grade prostatic intraepithelial neoplasia, meaning the cancer cells are looking just like normal cells. So we are not quite sure, but we can go home and sleep. Still under biopsy suspicious, it might be high-grade prostatic intraepithelial neoplasia, or it might be proliferative inflammatory atrophy. In the case where we're going to pick redness, swelling, signs of inflammation. And at the same time, the cells will appear smaller than the normal cells. And it could be atypical small acinar proliferation or glandular atypia. Under the biopsy suspicious condition, we can go home to sleep. It might be biopsy negative. Does it mean we go home to sleep? Well, let me round up before you know. When it is biopsy negative, it means we are not picking cancer cells. No cancer cells have been seen in the samples. It might be false negative in the sense that the biopsy needle might have inadvertently omitted the real tumor site. I have told you, everything about prostate cancer is not fixed. So now the biopsy report is saying biopsy negative. And I'm now pointing it to you right now that inadvertently, not intentionally, the needle could have omitted the real tumor site, even with the ultrasound and magnetic resonance imaging assisted core needle biopsy procedure. If other tests are suggesting that we are likely dealing with prostatic cancer here, then we cannot go home to sleep. Meaning, when I've said we cannot go home to sleep, I'm not saying for that very moment we won't sleep, but I meant that we are not closing the story here. So then we will do more things. Number one, we have to repeat this biopsy. Yes. We will have some other investigations done. So when it is negative, let's be sure it is truly negative. Let's do some other tests that we've not done. Even some tests that we've done but inconclusive, let's repeat them. In other words, for the first time of biopsy and the result comes back to be suspicious or negative, I will tag both as being inconclusive and we need to repeat biopsy. Yes. But when it is positive, then we move to the next stage, which is the report of the biopsy. Okay, here is a good bus stop to stop. For now. Let's examine adenocarcinoma, but I will be precise in bringing out the name as prostatic adenocarcinoma. And why that? Adenocarcinoma is not peculiar to the prostate gland. As a matter of fact, it is found in all glands, all organs that could secrete throughout the body. So adenocarcinoma is from the glandular epithelial cells of the prostate. Here, prostatic adenocarcinoma. That will account for about more than 90%. In fact, some authorities will put it at 95, others will put it at 99. You can almost close your eyes and tell anyone who could walk to your office and tell you that you have been diagnosed with prostatic cancer, that, okay, you are likely having prostatic adenocarcinoma, because greater than 90% of prostatic cancer diagnosed will be adenocarcinoma, prostatic adenocarcinoma or adenocarcinoma of the prostate. This is the cancer that is found where the ducts and tubes are. The lining of it that is responsible for the fluid secreted by the prostate gland. There are two subtypes of adenocarcinoma, and I want us to get the facts about them very clearly. Remember, before now I've been telling you it is neither here nor there. You will get one of the many reasons why it is so right now. And the acinar subtype of adenocarcinoma of the prostate is the commonest of all prostate cancers. It means it is commoner than prostatic ductal adenocarcinoma of the prostate. Now, the acinar. Now, the acinar cells are all over the prostate gland and through all the secreting tubes and ducts. Okay? This will grow from the back, from the posterior parts of the prostate gland. Please get this right. when you look at the diagram I have shown you earlier, you can see that posteriorly we have the large intestine, particularly the rectum. Okay, so it is pretty close to the rectum. So when acini adenocarcinoma is growing and digital rectal examination is done, the physician is most likely going to pick it through DRE. You can feel it there. And this one, we also shoot up the PSA. So PSA is high, digital rectal examination is picking something craggy and hard, and you say, okay, that is prostatic carcinoma. You are close to it, but let's have biopsy done, right? Now, another reason is that you may not have only that, you might have, other types present as well, right? But in the case of prostatic ductal adenocarcinoma, something is different. It's less common compared to the acini, right? But it is more dangerous. Well, it's good that it's not as common as the less dangerous one, okay? It can grow at the anterior or posterior or any part of the prostate gland. Unlike the acini that is growing more at the posterior part. This one can grow anywhere, within the prostate gland. But something is about to drop right now. Are you waiting for that? Get it. Prostatic ductal adenocarcinoma may not give you high level of PSA. So, when I've said repeatedly, that if you don't have high level of PSA, don't tell the patient, or you, the patient, don't go and be pumping champagne. If you have prostatic ductal adenocarcinoma, your PSA may not be high, yet you have a very dangerous cancer, more dangerous than the acid. Therefore, it is pretty easy to miss the diagnosis of prostatic ductal adenocarcinoma. Now, other types of prostatic cancer could be squamous cell carcinoma of the prostate sarcoma, transitional cell carcinoma. Remember, I have gone through transitional zone density the other time. When you get the prostate gland around the urethra zone, transitional zone, okay. Then the other type could be neuroendocrine tumors, like small cell carcinoma. So it's good we have been able to look at this so that we will get the entire picture why diagnosing prostate cancer seems to be a little bit cumbersome. Now, the histopathologist will send a report in form of Gleason system. Now, when you find Gleason grade 1, that is pretty nice in the sense that it is pointing to the fact that the cancerous tissue is looking just like the prostate tissue. But when it is grade 5, that is pretty bad, meaning that the cancerous tissue is looking grossly abnormal. The cells are abnormal. The growth pattern when compared to the normal prostate tissue is grossly abnormal. Different parts of the prostate gland will have different grades when it becomes cancerous. The pathologist will consider two areas that appear the most. Okay? Then he or she will write down the best cause in each area and then add together. The score in each of the two chosen areas will be added together to form Gleason's sum, like we have example there. Now, let me explain further what we get. Remember, the worst grade you can find in one area is 5. So, the highest Gleason's sum anyone could get from two areas, even if the person is having two areas and they are both having the worst grade, will be 10, meaning 5 plus 5. When you look at the result and you find two figures, like one on the left and the other on the right, like 3 plus 5, giving you the Gleason's sum of 8, take note of this. The 3 is the most appearing grade. Okay? So it doesn't mean the entire samples taken that is 3. No. It will be divided into two areas. The entire samples will be divided into two areas, right? I mean, of two areas will be taken, right? The commonest one in this case, in this example, is 3. And that is the most appearing grade. While 5 is the least appearing grade. So for this person, it's not a good news to have Gleason's sum of 8, but when you compare the good and the evil, if 3 that is better is appearing most, which means Gleason grade 3 is appearing most and Gleason grade 5 is appearing least, then it is better than having the opposite. Because 8 is 3 plus 5, could be 5 plus 3. If the worst will be written first. Okay. The worst will be written first if this is appearing most and it is grade 5 that is appearing most, that is pretty bad. And if grade 3 is appearing less, that is not good. So someone with Gleason's sum grade 8 and another person with Gleason's sum grade 8 may not likely have the same prognosis. Let me repeat and I'll move on from here. Gleason's sum grade 8 for two men may have two different prognoses. One has 3 written on the left, which means grade 3 is the most one appearing, while 5 is the least grade appearing. 5 is bad, but when we have most of the cells in grade 3, then the less, which is bad, that is A. B, the same grade 8, right? B, now let's look at B, the second man. The same Gleason's sum grade 8. If 5 is on the left, which means grade 5 is appearing most, and 3 is on the right, which means grade 3 is appearing less compared to the bad ones in grade 5, then the prognosis of this second man B is worse compared to the first man A, 3 and 5. So 3 and 5 is better than 5 and 3. Because whatever you find on the left, when it is Gleason system, whatever you find on the left means that is the grade that is the most common. Whatever you find on the right, that is the grade that is least common. Let's move on. Now, still on the system, Gleason 8 could be written in different ways. 3 plus 5 is equal to 8. Bracket Gleason 8. We are still Gleason 8. The same Gleason 8 could be written as Gleason 8, then you put bracket 3 plus 5, meaning grade 3, which is better compared to grade 5, is appearing most, while grade 5 is least, though very bad. So it is a better news for the man than the one with the reverse, 5 and 3. Then it could be reported as combined Gleason grade 8. I don't like this because you will not be able to tell precisely whether you are dealing with 3 plus 5 or 5 plus 3. Remember, I've said, and I'm repeating, 3 plus 5 is better compared to 5 plus 3, in the sense that 3 is a lesser grade, and it is the one appearing most. That is the one is reading first. 5 is the worst and is the least appearing. That is better than having the worst here appearing most and this less trouble on the right. And it could also be written as Gleason 8 over 10. Let me explain a little bit further here that 8 over 10 is saying the maximum we could get is 10. I mean, that is the worst that the Gleason could give us. That is the worst grade we can find. So out of the worst, the guy is having 8 over 10. That is not good at all. Also, like I've said, and I'm going to repeat and move on. Gleason 3 plus 5 is equal to 8. It is not the same as Gleason 5 plus 3. I won't waste time again because I've explained this over and over, but let me say it for the last time. The reason is that what is written first on the left, that is the one appearing the most. And in this first man, 3 is a lesser evil compared to 5, the worst grade. So if the most bad ones appearing will be 3, and 5 is less appearing compared to the 3, that is better for the man. Unlike the second man, that the most ones appearing will be the worst, number 5, and the least ones appearing will be the better one, 3. So the man with 5 plus 3 is worse compared to the man with 3 plus 5, though they both have Gleason 8. I hope you got it. Give me a thumbs up. Briefly, it is possible to have Gleason grade reported as similar, like 4 plus 4, 3 plus 3, 5 plus 5. In all, it means that we are dealing with the same pattern. So it will be reported like that, so that we have both sides compared. It's all the same. It's all the same grade. So more bad areas than good will be reported as we have explained earlier. And why that? So that appropriate actions could be taken by the physician. When the Gleason is increasing, it means that the chances of having cancer is increasing. But let me finally touch this, that the worst you can have is 5 plus 5, that is 10. When it is 7 over 10, like I've explained earlier, 7 is what the patient is having, 10 is the worst anyone could have. So having 10 out of 7, it means you are not yet 8, you are not yet 9, and you are not having the worst. you might come across sometimes under the biopsy and glycine system as well differentiated. If you find that, that means it is of low grade. It is not aggressive. It is growing very slowly and likely going to spread slowly. So in this case, you are okay with watchful and waiting if the man is greater than 60 years. And in this case, you may find glycine grade 3, 4. I mean, when you add both sides together, you're not going to get something so high. The maximum you can get there will be 6. That is well differentiated. Okay, and the glycine grade will not be high because once you reach 7, the story is changing. In the case of poorly differentiated, it means it is of high grade. When you get a report and it's written poorly differentiated, something bad is going on here. That is high grade. And this is expected to be aggressive. It is growing very fastly or rapidly, and it's going to spread in the same fashion. So, glycine 8 and above will be what we're likely going to pick here. The higher the number of glycine, the worse the prognosis, you know that. So, like I said, glycine 3 plus 5 means that most of the tumor is grade 3, while less of the tumor is grade 5. So, I'm repeating that here. Now, the moderately differentiated means that it is intermediate grade, right? And the glycine score here will be 7. It can change for the worse from 7 to 8, 9, or 10. In this case, we will do something. We will do more tests, okay, to determine what the treatment pattern will be. Still on glycine system, what I've been saying before now to so many people is pretty complex. Then the experts looked for a way to resolve that. So I tagged it as a solution to the complexity of glycine system. So to get out of that, they embark on grouping into 6, 7, 8, 9, and 10. Okay, a new system of reporting is then out. Then, grade group 1 of prostatic cancer will be glycine less than or equal to 6. So anything glycine grade 1, 2, 3, 4, and 5, when you sum everything together, up to 6 is grade group 1, prostatic carcinoma. Grade group 2 will be glycine 3 plus 4, which is equal to 7. You can now see this. While grade group 3 will be glycine grade 4 plus 3, which is equal to 7. You can see that there's difference between 3 plus 4 and 4 plus 3, and they are still the same 7. So, because you will agree that grade 2 is less of evil compared to grade 3. Just like what I've said, the worst one is on the left. The less evil is on the right. If the number has switched here from the good ones being, the worst one being less compared to higher number of good ones, here the bad ones are more than the good ones. So that is why this one is carrying a worse prognosis compared to grade 2. Why grade group 4 will be glycine 8. Either 3 plus 5 or 5 plus 3. 8 is always bad, when you compare that to 7. And of course, grade group 5 of prostatic carcinoma will be anything 9 and 10. I'm not sure, but my assumption is that they have agreed to put 9 to 10 together because what is the difference between 9 and 10 anyways? No, someone at grade 9 is as bad as grade 10. Okay, here's the question. Is grazing system magical? Meaning, is it solving a problem? When it comes to prostatic cancer prognosis, even the grazing system is non-magical. Definitely no. And why that? I have said it and I'm going to repeat it. Everything about prostate cancer is all over the map. So we'll look for it all over the place. So what is happening? Why is this not the end of the road? Why can't we rely on this completely? We can inadvertently miss the very spot where the aggressive tumor is. Like we said, on the left, the worst ones, on the right, the good ones. You write 3 plus 5, you sum that to be 8. But what if we have missed the spot that is, harboring the worst cells? Human error in reporting is what we should give room for, right? So it might be. Some believe that in 20% of cases, the cancer is worse than glazing report would have given us through biopsy. Then, if that is not the last about how to make the definitive diagnosis, then what is the way out? Okay, we should use glazing as one of the many tools to make final diagnosis. That's it. We will add the results of other investigations, measures. Then we will put that with what the glazing report through biopsy is telling us. Then we can diagnose prostatic cancer definitively. Isn't this a big job? Herculean task, right? It is. So finally, we can say that we can make definitive diagnosis of prostatic cancer and go home to sleep, figuratively, if the biopsy is done, glazing system report and grading is here. We have what the bone scan is saying. The ultrasound is telling us something. Digital rectal examination has pointed to something. We have other tests that could help us for comorbidities, already establishing that or ruling them out. We have the PSA. We have the prostate acid phosphatase. We have the X-ray. We have the bone scan. Name it. We put all together and then tell the patient, this is the diagnosis. Okay, TNM classification of prostatic carcinoma. T is all about the tissue, that the tumor is too small to be seen through the ultrasound or palpation. T1 has T1A, T1B, T1C. When it is less than 5% of the removed tissue, it is T1A. When it is equal to 5%, it is T1B. When it is found through biopsy after PSA has been raised, it is T1C. Now, T2 is all about the fact that the tumor is inside the prostate gland completely, while T3 is telling us that the tumor has penetrated through the capsule of the prostate gland. That is T3. T3A saying the same thing, penetrating through the capsule, covering the prostate gland, while T3B is telling us that it has spread into the tubes that are carrying the same. Now, T4 means that the tumor has spread to the neighboring organs. The bladder is suffering now, pelvic wall affected, then rectum affected. The neighbors are suffering. While the N here will be the clue about the lymph node involvement, whether it has spread to the lymph nodes or not. We have NO, means the nearby lymph nodes do not contain the cancerous cells from the prostate gland. While N1 means there are cancerous cells in the lymph nodes around the prostate gland. Now, M is all about metastasis or not, whether we are dealing with distant metastasis or not. So MO means there is no distant metastasis. M1 means it has metastasized beyond the pelvic region. In that case, we want to find out, is it M1A, M1B, or M1C, where M1A means it is found in the lymph nodes outside the pelvic region, while M1B means the cancer cells are already found in the bone, while M1C means it has gone far away from the pelvic region and is now far, in the torso, the chest region, found in the lungs and even above. There are other tests that we can do to support the health status of this man. Let's have complete blood count done. There might be even having leukemia, we don't know. Let's have the urinalysis done. Maybe that will point to having, random blood sugar or fasting blood sugar done when we pick a level of glucose. And then maybe that will be the first time you will know that he has diabetes mellitus. Let's have nitrite. Though that may not be definitive as per knowing whether there is urinary tract infection or not, but that will set us on motion to do more. Some will even have procalcitonin done. Urine microscopy culture and sensitivity, just to be sure it is not urinary tract infection. We can have blood culture, blood MCS. We can have electrolytes done so that we will know that before subjecting this man to so and so pattern of treatment, he or she has the body that could take it. Because when we pick other comorbidities, then that, in fact, mere taking the blood pressure can point to hypertension. And who knows if it's going to be, hypertensive urgency. Might even be hypertensive emergency. So we want to rule all other disease conditions out before making up our mind whether or not this man will take so and so pattern of treatment in addition to the age or not. So don't let me waste your time. Let's move straight to the treatment of prostate cancer.